First, place the patient in a supine position and identify the important superficial anatomical landmarks. Note the position and course of the anterior and posterior heads of the sternocleidomastoid muscle and the clavicle. The triangle formed by these structures is essential in choosing an entrance site for all three internal jugular approaches. Additionally, locate the carotid pulsation. The heads of the sternocleidomastoid muscle and clavicle are outlined. A wide area of skin is prepped with betadine. Note that all three possible internal jugular approaches and the ipsilateral subclavian site are included in the sterile prep. After applying the betadine, you must allow enough time to let it dry. The contents of the equipment tray include sterile drapes, sterile gauze, a flexible guide wire contained within a sheath, an introducer needle attached to a syringe, local anesthetic, and a smaller needle and syringe used to inject local anesthesia. Fill the syringe with lidocaine. After the betadine has dried, apply the sterile drape with the opening over the insertion point. Place sterile gauze adjacent to the opening in order to wipe up any blood from the needle stick. Palpate the posterior head of the sternocleidomastoid muscle and inject a superficial wheal of lidocaine. Then inject lidocaine more deeply along the path you plan to follow with the introducer needle. This entrance spot may be identified just posterior to where the external jugular vein crosses the sternocleidomastoid muscle, or by selecting the midpoint of the muscle. Next, advance the introducer needle posterior to the lateral head of the sternocleidomastoid muscle. The needle is directed slightly anterior toward your thumb, resting on the suprasternal notch. Advance the needle slowly with negative pressure on the syringe. If the initial pass is unsuccessful, withdraw the needle, palpate the sternocleidomastoid muscle to confirm you are in the right place, and redirect the needle slightly more inferiorly. The sudden return of dark, non-pulsatile blood indicates you are in a vein. Take off the syringe and advance the guide wire through the introducer needle. Never let the whole guide wire enter the patient. Once the guide wire is in, the introducer needle is removed, leaving the guide wire in place. Next, make a small nick in the skin with a scalpel at the entry point of the guide wire. In this case, an introducer is being placed for a pulmonary artery catheter. The dilator is placed through the lumen of the introducer sheath, and the two are advanced together as a unit over the guide wire. Note the side port through which you can infuse IV fluids. Thread the wire through the lumen of the dilator and advance the dilator and introducer together over the wire. Note that the operator never loses sight of the guide wire. The dilator is advanced with a slight twisting motion, and once in place, the dilator and guide wire are removed, leaving the introducer sheath as the only connection to the intravascular space. The free return of blood through the side port after the stopcock has been opened confirms the intravascular location of the introducer. Place a suture through the skin about a ½ centimeter from the catheter hub to form an anchor. Place several knots in the anchor. Loop the suture around the catheter several times and then secure with several additional knots. Excessively tight knots can be painful and difficult to remove. Excessively loose knots can lead to catheter migration.